It is 8 o'clock and
We are live.
Yeah. Namaste. Myself, Dr. Archana Dwivedi, Midlife Management Committee Fogsi, welcome you to 108 episode of Gyan Pravah. Putting up as a century was a real enlightenment to all of us. We happily enjoyed the century, and now we are entering in the second part of the century. We'll confirm 200 episodes and many more to come. So today, myself, I have welcomed our President, Dr. Sunita Tandulwadkar, Madam, and Dr. Nimit Khera for today's session. I think which is very important when we talk about insomnia, especially when we are into the perimenopausal, menopausal, and the lady who's struggling with all the daily chores and trying to maintain herself in amidst the all the chaos. But here I present you the lady in front of me who has been energetic, inspirational, smiling all the time, giving us a confidence boost and whatnot. Dr. Nimit, she has given us a slogan, Ek Rashtra, Ek Mission. Swasth Nari, Samruddha Vatan, Har Ghar Foxian. So with sleep problems in every phase of life of a woman, like when Har Ghar Foxian we say with her, it brings automatic smile to our face. She is also doing depression study. We have got a special study going on where we are looking into the questionnaires. She has prepared a special questionnaires where we are going to the mass and the mob in the pan India, where we are studying on whatever problem she is facing when she is into perimenopause so that we can help her the most. So presenting to you Dr. Sunita Tandulwadkar, Madam, who is our president currently, and she has been a pivotal role when it comes to multi-dimensional development of a lady. She is accomplished doctor, accomplished human being, and we also see a spiritual gain when we talk to her. So, Madam is here, and I would like to have some words of wisdom from her.
Thank you, Archana. Thank you always for being such a kind and generous use of the words. I'm so glad that you have taken Dr. Nimit Khera today and you are going to have your podcast on a very important topic and usually neglected topic. So Archana, you have always come out with one of the best podcast series tackling different aspects of life. And Dr. Khera, it is our pleasure that every day, 8 o'clock, more than now, 109th episode, maybe, or 110th episode of Archana, we are doing with our team Evangel. And every day we are evolved with so many faculty. I think it helped us because sometimes there may be from non-academic background, spiritual, political, philosophical, philanthropic. So much to learn. And Archana, you always come out with the best podcast. As our pattern is, I'll be joining from the viewers link, and you both will be in the platform enjoying your podcast, enjoying the dialogue, and we'll be happy to listen to you. Thank you, Archana, and goodbye.
Thank you, ma'am. Your commitment addressing the critical challenges in the women health, enhancing the healthcare accessibility, educating them, and preventing care across the India keeps us going. Coming to our subject, we have Dr. Nimit Khera, sir, over here, who is a consultant professor in respiration and sleep medicine. He is presently working with Sri Krishna Hospital, Pramukh Swami Medical College, Bhai Kaka University, Karamsad, Gujarat. He is a consultant at Adi Lungs and Sleep Clinic. He has done his fellowship in sleep medicine from Storybrooke University Hospital, New York, USA. He is trained in sleep medicine, Guy's and St. Thomas NHS Foundation Trust, UK. He is also a fellow of Royal College of Physicians of Edinburgh and Glasgow. He is also a clinical examiner, MRCP UK. So it's a privilege to have you, sir, because when we talk about sleep, this is my agenda as working for the Midlife Management Committee this year to talk about sleep, learn about sleep, because it is very important. When we do all the studies concerned with the midlife lady, we talk about different aspects, bone, muscle, the hormonal changes, skin, hot flashes, everything. But the main key point which bothers everybody is lack of sleep. That is actually when I was going to the studies before starting commencement of this talk with you, I was shocked to see that almost 60 to 70% women especially when they have got a more predisposition, like 1.4 times higher than men, to suffer from sleep disorders. I would term as disorders because I would be enlightened more as I talk to you in this coming 1 hour talking terms. And the heightened psychiatric morbidity leads to a woman who is accomplished yet having something empty in herself, not able to be at peace with herself. So thank you, sir, for joining us. And my first question to you, I would talk as a layman. If I have to talk about insomnia, lack of sleep, what does insomnia exactly mean, and how can we define insomnia?
Sure. Firstly, namaste. Thank you for inviting me. And it's a privilege to meet dedicated doctors like you and Madam. And I would like to congratulate you first on the century of podcasts. Uh, and please don't call me sir, just call me Nimit. Nimit
Sure.
is fine. So, coming to the first question, what is insomnia? If we go strictly by definition, um, various organizations have defined insomnia. In medical terms, it would be acute or chronic insomnia. So, by definition, um, it could be problem with initiating sleep or problem with maintaining sleep or early morning awakenings along with daytime symptoms affecting the daily routine or daily function of a person. If insomnia symptoms are for less than 3 months, it is termed as acute insomnia. And I'm sure as medical students, we all have experienced that during our final MBBS or our MD or MS exams. So that is a short-term insomnia, which is situational and it depends upon the circumstances. Chronic insomnia, by definition, is insomnia symptoms for more than 3 nights a week, which is persistent beyond 3 months. So that is chronic insomnia. And to define insomnia, um, medical problems leading to sleep disturbances or sleep disturbance and psychiatric comorbidities should be ruled out. But in clinical practice, often these things are quite overlapping. So, one of my co-fellow in the US used to say that patients don't read books. So, very often we do not get those classical book picture patients. Our patients have a variety of presentations, and frequently the symptoms are quite overlapping. So I hope this answers the question about definition of insomnia.
Perfectly, sir. You are very right, because many ladies who come, they say the main common complaint is that I have difficulty in falling asleep and I awake frequently. Then restoration of sleep is again a difficult situation for them. And morning they are coming up with a brain fog, trying to cope up with all the problems around them. So I think we have got a rationale when we discuss about insomnia or sleep disorders in female. How do you go about it?
It is absolutely rational to discuss insomnia in this era, and I would like to discuss a couple of facts about insomnia. About 30 to 40% of adults experience insomnia at some point in their life. So it's a big problem. Secondly, um, I believe this is a group of gynecologists mainly.
Yes, yes, yes.
So, um, if I speak in very contextual term, in our Indian scenario, uh, ladies or females would go to a gynecologist for any kind of problem. So it would be quite common for gynecologists in our country to have females with insomnia because they would prefer to go to, a doctor who is familiar to them, irrespective of their problem. So, in many of the cases, the gynecologist would be the first point of contact for these ladies who are suffering from insomnia. So, it is very, very rational to discuss insomnia. If we talk about the world data, in the US, they say that about 6 or 7 people out of 10 experience some sort of sleep related problem and insomnia in their lifetime. So the rationale is very clear. We need to have more awareness, we need to have more discussion, and we need to keep on discussing and studying and diagnosing and treating insomnia, which is today it is just like a tip of the iceberg, and the problem is quite
Bigger.
significant.
So, sir, Dr. Nimit, is insomnia, you feel it is a neglected and menopausal transition phase? People do come up with other problems rather than insomnia. And how do I have to, probably how to diagnose that she's suffering and when to refer to you? So, how do I diagnose that patient?
Yeah, so the
Or rather,
first,
identify is a right word, probably.
yes, so I will answer this question to the point. The first question is how do they present?
Hmm.
So they have difficulty initiating sleep, which is sleep onset insomnia. Usually people fall asleep within 10 to 15 minutes after they decide to fall asleep. If it is taking, a couple of hours for somebody to fall asleep, it is definitely sleep onset insomnia. The other presentation would be um, a lady who has no difficulty falling asleep, but she keeps on waking up in the middle of the night several times, and then her mind starts racing, and she is not able to control the mind. She is not able to get back to sleep. So that would be sleep maintenance insomnia. And some people would complain of early morning awakenings, like about 3 o'clock, 4 o'clock, 5 o'clock in the morning, and then unable to get back to sleep. So these are very clear cut presentations of sleep apnea, insomnia. But sometimes some weird presentations would be there. Like somebody would come with a depressed mood, or irritability, or anxiety, or depression, or changes in their daytime functioning. So these all could be the potential symptoms of insomnia. Now comes the question of diagnosis. The diagnosis of insomnia largely remains clinical. There are some diagnostic tools. I always emphasize on a good sleep history. So just just like we have a respiratory history or obstetric history or gynecological history. Similarly, there is a sleep history, and if we were to take a good history, it would take about 40 to 50 minutes at least. So sleep related problems or insomnia requires a clinical assessment first. Then there are some diagnostic tools like sleep diary. We request the patients to maintain sleep diary. It has variety of components, and we analyze their sleep for about 2 weeks time. In addition to this, there is a test which is actigraphy. So it is a kind of watch which is given for 2 to 3 weeks to the patients, and it is called as actigraphy. So the active watch detects the level of sleep and wakefulness, and it gives us a very clear idea about um, the exact duration of sleep of the patient, because many of the times there might be misconception in the patient's mind. Patient would say that I am sleeping only for 4 hours, but the actigraphy would show that the patient is in fact sleeping for 7 hours. So these are the diagnostic tools, but mainly the diagnosis remains clinical.
So perfectly said. I think sleep diary and history taking is something very important for any doctor or any care provider to understand the problem in a better way. So taking it into a different level, is sleep quality important and quantifiable? As you said, active watch is there. So can we quantify for these patients?
Yes. So one is subjective assessment, other thing is objective assessment. Subjective severity of problem is determined by the history, sleep history, and there is a Pittsburgh Sleep Quality Index, which is a reliable and validated system of questionnaire and scoring. So it gives us an idea about the quality of sleep. There is another questionnaire which is Insomnia Severity Index (ISI), and it is also a very useful tool in order to identify the severity of sleep apnea. So yes, quality can be determined, it can be measured, and it is important.
And as you said, questionnaires are there always to help, and then we have to quantify the sleep because presentation is different for every patient. We have to first understand which patient needs what type of treatment, probably. So, do you feel that urbanization has been a leading cause of insomnia? Rural habits were more better. सात शाम को 7 बजे सो गए, खा करके फिर सुबह जल्दी उठ गए. Was, I mean, something linked? Do you feel there's a link to that?
Yeah, that's a very good question, and I live in an area which is quite in between rural and urban. So on one side of my home, I have a small village, and the other side there is a good town. Yes, the rural habits were better. People have their meal in the evening at 7 o'clock. They they do not have any screen time after they have meals, which is good. Uh, if we talk about the women in urbanized times, two people earning has become a norm, which was not the case previously. So today's women have greater responsibilities than the past. So they take care of their children, they take care of the home, they take care of the profession. So these are the gifts of urbanization. Um, Along with that, all kinds of pollutions, air pollution, noise pollution, and the biggest polluter of our mind is the screen. Uh, and Very frequently, we get insomnia patients who have insomnia because they are not able to switch their mobile phone off at least 1 hour before going to sleep. So yes, we can keep on discussing about the effects of urbanization on sleep, but it is definitely a major factor, not only in women, but especially in adolescents age group as well.
So I think the problems which we have faced in later life will come earlier nowadays because of the screen time, as you said already. Because if mobile is not there, the tablet is functioning, or maybe the TV is running, or telephone is there. There's so many things. People are being like surrounded with so many electronic gadgets. Very hard. I think there should be a de-addiction center in near future to be de-addicted from the mobile and electronic gadgets.
Yeah, I agree
So
with you.
yeah. So do you feel that gender is really related with insomnia? Because I was going through the literature and thought that being a female gender, we have got a like more predisposition. Do you feel that this is a truth or a myth in my mind?
It is absolutely true. I completely agree with you. And if I was to give you some statistics, women are 2.5 to 3 times
Mm.
more likely to get insomnia than men, and especially during their pregnancy, uh, perimenopausal period, postmenopausal period, and postpartum period. These all are the important time frames where women are very likely to develop insomnia. So you are very right. women are at a greater risk of insomnia. Yes.
So sometimes I hear there's a primary insomnia, then the secondary insomnia. So what do these things, I mean, they are interlinked. Where do they start? How do they end? Is primary linked with secondary? So there are so many thought processes coming out. I think you're the best person to tell me what is primary, what is secondary insomnia.
Yeah, so once again, it depends upon whom you are asking this question. Because I had several discussions about this with my psychiatrist friends, and probably if you ask some psychiatrist, they would say some of them would say that there is nothing like primary insomnia.
Yeah.
There has to be something underlying, but if you ask somebody um, like me, who is a sleep physician, I would agree that there is primary insomnia and secondary insomnia, because I have seen hundreds of cases of primary insomnia where there is no other comorbidity which could be contributing to insomnia, like any psychiatric problems, anxiety, depression, personality problems, uh, and any medical problems like neurological problems, Parkinsonism, dementia, or cardiac problems. So, variety of chronic pain, fibromyalgia, arthritis, everything contributes to insomnia. So, if any of these things are associated, it would be secondary insomnia. If they are not associated, it would be primary insomnia.
I think you're very true because if lady or any gender is suffering from pain, like even the knee joint, so the pain would be the predisposing factor why she's not able to sleep. So I think that will be categorized into secondary. And
Yes.
I think you'll have to soon put a word iatrogenic as well with increasing electronic gadgets. So probably we are inventing a new term over here together. But I think medical disorders, I would like you to focus more that, I mean, they are the things because comorbid conditions we cannot avoid. 35 plus, I mean, some other things there. I mean, if I have to say a cohort of 100 patients, probably I'll find 80% suffering from some or the other comorbid conditions when they are, I'm racing with the time, age, doing so many things, trying to multitask. So how often do you see such patients and medical disorders as an important link to insomnia?
Yes, of course, there is a long list of medical conditions which are associated with insomnia. And if I talk about the real life patients that I have seen, especially women who have fibromyalgia, rheumatoid arthritis, or any other sort of arthritis, chronic pain, chronic back problems, pelvic inflammatory diseases, migraines, uh, these are all are associated with insomnia. And of course cardiac problems, kidney problems, any kind of medical disorder, neurologic problems like dementia and Parkinsonism, stroke, they all are associated with insomnia. So in those cases, um, uh, it of course it would be our target to correct the primary problem, and that would take care of insomnia. I would like to specifically emphasize on psychiatric problems because the symptoms are quite overlapping,
Yeah.
and there is a significant stigma still in our country, especially amongst women who have some psychiatric problems, but they are not able to receive the timely care that they should be.
So I think you very rightly said because as you said, anxiety, panic attacks. I think now no age is bar. Actually, peer pressure is so much at the school level also that it is coming up. So when we talk about the perimenopausal health, I think we have to start from in womb because a mother who's pregnant, if she herself has the anxiety predisposition, probably the genetic transition is going on with the baby as well. So with today's scenario, and one thing which I would like to add on when you talk about the medical disorder, genitourinary syndrome of menopause. the urinary dysfunctions,
Yeah.
and the physical inability. She's feeling like pee, and she, before she goes to the bathroom, she leaks out. So that becomes a nighttime trouble because she's going to clean herself, and there are so many other things associated. That sleep cycle is going to be disturbed. And I think, Dr. Nimit, overthinking, and probably if we look into the Indian scenario of house hierarchy, I think most of the women still have no speech or no voice of confidence when it comes to their problems. So I think that silent suffering slowly gets add-ons and probably present as a bigger, as you said, tip of the iceberg. I think till the blast happens, I think if we address our patients in a premature condition, but a very early phase, probably will be helping them the most. And medical disorders are here to stay with the changing scenarios, the environment, the epigenetics. So we have to take care of our sleep. As Dr. Nimit is already saying, that quality and quantity of sleep is very important to avoid brain fogging the next day. So, what are the treatment options? If I, as a lay gynecologist, basic gynecologist, I would say that like if I go, have to refer my patient to a psychiatrist, there will be a medicine, the whole list would be there. So, in your opinion, is the medicine enough, or we have to think of out of the box something else for these patients?
See, if we speak about the guidelines, American guidelines, European and British guidelines, the first line of treatment for insomnia is CBTI, which is cognitive behavior therapy for insomnia. Medications are the second line treatment. Now, unfortunately, we do not have a good number of clinical psychologists who have specialized in CBTI or cognitive behavior therapy for insomnia. Now, CBT is quite common for panic attacks and PTSD and OCD, other psychiatric problems, but it is difficult to find a psychologist who specializes in insomnia. So, according to all the international guidelines, cognitive behavior therapy for insomnia is the first line of approach. Usually, it is a 6 to 8 weeks program and it has several components. It is beyond the scope of this talk because CBTI itself is a big
It's a big
discussion.
topic here.
Yeah, so I can discuss about some of the recent advances which are going in CBTI. Nowadays, there is another term which is DCBTI, which is digital CBTI.
Mm-hmm.
And in the UK, they have a digital platform which is sleepio.com. So you can download the application and it is a kind of digital CBTI. So thousands of patients can get the benefit of CBTI at the same time. And if my assumption is correct, in coming years, very soon, we will have AI agents providing CBTI because there are not going to be enough psychologists for CBTI. So CBTI is the first line of treatment. Second line, medications. The first choice of medications would be um, least addictive kind of drugs like melatonin.
Mm-hmm.
Magnesium supplement works wonderfully. Then comes the Z drugs, that is zolpidem and zopiclone, S-zopiclone. And if still the insomnia is resistant, benzodiazepines can be used. But there are significant risks associated with long-term usage of the medications. So according to all the guidelines, medications are not recommended for more than a few weeks' time. Although in our clinical practice, we frequently see that an insomnia patient is immediately prescribed a medication and they are taking them for like 20, 30, 40 years. So medications are not the first line of treatment. I would like to add something from our Indian culture,
Mhm.
ashwagandha is quite effective for insomnia. Now, I have seen more number of patients who have tried ashwagandha in the US and the UK than I have seen in
Yes.
India.
Yeah.
So I hope that answers your question.
Yeah, yeah. Surely said, sir, because I would just like to share a weird incident. There is one of my friends in the metro doing very well. So they go to the psychiatrist or the counselors just to spend 1 hour to let out
Yeah.
so that they can sleep better. I think this culture is sooner or later going to seep in because uh, from here originates the word talking therapy. So any takes on that? What is talking therapy? I mean, I have read that there are four components are there, and you become more sorted out because you don't feel that they are judgmental to you because it's not going to. If you discuss among the pals, the things are going to spread about you. With the counselor, probably it's more confidential, and the talking therapy is sorting out, shelving the problems in our mind. Do you have any weird incidents or real incidents to share with us on this?
Uh, if I was to give examples, uh, I could discuss hundreds of patients who were just happy after having a 45-minute consultation. The crux of their problem was only 5 minutes, but the rest of the time was about their business, their finances, their losses, their gains, their challenges in their businesses, their cats, their dogs. So I had one patient when I was doing the fellowship in the US, and the lady um, was supposed to have a sleep study, but she could not do it. She said that I have a dog at my home, and my dog is suffering from congestive cardiac failure. So I cannot leave my dog alone at my home, and she refused to get a sleep study. And she talked about her dog for half an hour. Now, in India, we are fortunate to have people around us, to have families together. But as you earlier said, the urbanization is taking away the peace of mind. So the talk therapy can, very much happen within the family, within the group of friends. And I think in today's world, everybody wants people to talk without judgment.
Perfectly said. So everybody wants to have to go person. So that is important in everybody's life. So, sir, discussing all these things, treatment options and everything, there's a term known as sleep hygiene. So I think we need to practice it. So what is exactly sleep hygiene? How would you define? How do you want to go about it? What do you want us to know as a awareness part of sleep hygiene? How is it going to be beneficial to most of us?
Yeah, so sleep hygiene once again can be a different topic for an entire talk of 1 hour, but I will just discuss the main points. We know everything about body hygiene. We are aware about sleep hygiene. We know what to do, but sometimes it is easier said than done. So it is difficult to put it into practice. Now, the main points in sleep hygiene: have a regular bedtime and wake up time. I'm just giving you the key points. Turn off the lights, television, screen, switch off the mobile phone at least 1 hour before going to sleep. Avoid any kind of blue light, I mean white light or whatever light we have. The room should be very dark at the time of falling asleep. I have seen some patients who, fall asleep while their television is on
Mm.
and the lights are on. So that's not a good practice. The environment should be comfortable. The temperature should be comfortable. Um, there are two mistakes which insomniacs commonly do. If somebody has sleep maintenance insomnia, when they wake up in the middle of the night, the first thing that they would do is look at the clock.
Yeah,
That
very
that
common. Yeah.
that should not be done. So if somebody is waking up in the middle of the night, somebody has insomnia, never look at the clock. And second mistake, uh, even if people are not able to fall asleep or maintain sleep, they remain in their bed. They do not get out of the bed. They keep on waiting for sleep to arrive for hours and hours and hours together.
Mhm.
So there is a dictum that the bedroom is only for two things: sleep and intimacy. If you are not doing any of these two things, don't get into the bedroom. If somebody is not able to sleep, stay out of the bedroom. Bedroom is only for two things. So these are the main points about sleep hygiene.
Yeah, and some people have a habit that daytime उनको time नहीं मिला तो शाम को खूब सारा exercise करके I'm trying to maintain my gym time. So I think that is also one thing which should never be done. At least 2 to 3 hours, rather 4 hours prior, only light exercises can be advised, sir, as you can.
Very, very true, very true. Evening exercise can compromise the quality of sleep. And just yesterday, an article is published in the Journal of Clinical Sleep Medicine about this, that people should avoid evening exercises in order to get better quality sleep.
Because you are unnecessarily playing with the receptors and getting the dopamine surge.
Exactly,
Whereas we need to be on more GABAergic sites so that we are
exactly.
able to sleep in a better way.
Very
And
right.
about the meals, Dr. Nimit, because we Indians love to have good food before we go to sleep. So how is it interfering with their sleep quality?
So, as we say, every Indian knows that breakfast should be like a king, lunch should be like a common man, and the dinner should be like a beggar. I hope
So I
that
think
answers.
we invert the pyramid when it comes to
Yeah.
more being affectionate in the family, more tail and more everything is there, and we give a good heavy diet in the night. So all yours, sir. What do you want to say on that?
See, diet, uh, you can find on the internet, there are certain foods which are rich in, serotonin and even melatonin like chemicals. So they are good for inducing sleep. Of course, very heavy meals are to be avoided. And we live in a dry state, but it is just namesake. So alcohol should be avoided. It spoils the quality of sleep. It leads to early morning awakenings. So yes, we know everything about diet, but as I said, it is easier said than done. We know, but somehow we are not conscious of our diet, and we are not able to follow those recommendations.
You're very right, sir, because knowing everything, in spite of that, the late night things and like अमुक जो cultures हैं जिसमें हम लोग खाना खाने के बाद people are fond of having chal coffee पी के आते हैं. That coffee culture is also destroying the sleep very much. Coffee or tea, anything. Before bedtime, I think it should be restricted.
Uh,
Caffeine intake is.
yeah, not only before bedtime, it is recommended that people who have insomnia or in general, caffeine intake after 3 p.m. is not recommended, because even a cup of coffee at 5 o'clock in the evening could impair the quality of sleep at night. So, no caffeinated drinks after 3 p.m.
That's very right because there should be a time bound. If we need to auto instruct our body that you have to sleep, probably we'll have to become more conscious and aware. And I think conscious efforts do help us in a long term. Like if we say somebody go for meditation, it is very difficult to meditate at one go. But in a process of time, you start understanding what is peace and what is being peaceful to yourself and go
Mm.
to sleep. So, I would say that we are not, some people will not be able to follow that. So probably we need to scare them with certain things. So what are the late consequences if the long prolonged insomnia is going to be there? They need to be aware that they are harming themselves in a long run.
Lot of consequences, a long list. Firstly, insomnia would impair the overall quality of life, daytime functioning, that would lead to professional problems. In the daytime, these people can become really irritable and angry, anxious, depressed. Other comorbid conditions are more likely to develop, like metabolic problems. Um, Sleep deprivation is associated with impaired glucose metabolism, so it could be associated with diabetes, cardiac problems, hypertension, stroke, um, dementia, lot of problems. Uh, so there is a long list of problems, and in a recent paper, um, somebody investigated that chronic sleep deprivation can also increase the chances of cancer.
Hmm.
That is something really concerning. And if you talk, if we talk about your community of gynecologists, if a pregnant woman is not sleeping well, it is going to affect the fetus. It might have a long lasting effect not only on the mother but on the baby as well. um, yes, so there is a long list of eh, um, complications or undesired effects if insomnia is not corrected. Uh, it is it is said that if somebody doesn't sleep for 1 month, 30 days consecutively, that person would die.
Oh, that's very shocking index, but I think we need to be aware of this at this point of time with Dr. Nimit talking about it. Because see, when we talk about the mental health, I think GIT, heart, bones, muscles, everything is going to suffer. So we need to be very, very conscious about getting a good sleep. At least I think 6 to 7 hours sleep. What is the data,
Uh,
sir,
yeah,
here?
so it would be 7 to 9 hours, anywhere between 7 and 9 hours. So some people feel refreshed even after 6 or 7 hours. Some people are genetically short sleepers, and it is quite okay for them. Some people require 9 hours of sleep. Um, I can give you some examples. Einstein used to sleep for 11 hours, and you know, there are some other. One of the U.S. presidents used to sleep only for 4 hours. So there is a wide variation, but we are talking about extremes here. Uh, but the average is 7 to 9 hours, and anything less than 7 hours. Uh, for a normal human being, we are not talking about extraordinary people.
Sorry.
For
So
any normal human being, anything less than 7 hours is going to impact the multiple systems in a negative manner.
quality of life, the thought process, the brain fogging definitely is going to affect. So
Yeah,
there will be a lady like me who will ask if I sleep in divided, is that counted or one go 7 hours?
it would
Like
be
I sleep
yeah, it would be recommended to have 7 hours of sleep at a stretch,
stretch.
because every 90 minutes there is a cycle of REM. Then there are sleep stages that we go through, N1, N2, N3, and then REM. So there has to be certain amount and number of cycles. So we get REM sleep about every 90 minutes, and REM sleep increases as we go toward the morning. So if somebody is sleeping for 2 hours, and then 3 hours, again 2 hours, that broken sleep is not not an ideal scenario.
So at a stretch is accountable thing for the sleep, and as sir has rightly said, we have to have a circadian rhythm in which the REM sleep is very, very important to keep like everything needs to be rejuvenated and regenerated. I think sleep is the time when the body is rejuvenating, resting, and preparing for the next day. So very true. It was actually very good to talk to you about certain pointers which happen to be a daily concern for all of us. As a gynecologist, probably when I have to give a solution like hot flushes are there, women suffer from that, anxiety, panic attacks, there are certain ailments where the menopause hormone therapy does help. So I think initiated early is the best thing to have a better sleep and better quality. So do you come across, I mean, I'm like trying to tell that MHT is also a very good solution here, if we talk in terms of ladies.
Yeah, so I think your question is about HRT, right? Hormone
HRT.
replacement
That's
therapy.
menopause
Yeah,
hormone therapy is the newer term, sir. So we
right,
use that nowadays.
right. Yeah, I have seen a good number of cases, perimenopause, postmenopausal women who were started on HRT and then their sleep improved. But I would like to consider the holistic picture. Um, this is my opinion because with HRT we are manipulating the natural cycle of our body. We are not following the nature's course, and HRT is not without side effects. So I am not a gynecologist, but we are manipulating the gift of God which has created, and we are inducing some hormonal changes which might have some side effects as well. People might say that there are newer HRTs which do not have side effects or this and that, but this is my opinion. I would be very careful before starting, before recommending HRT for insomnia.
Uh, I think you are right, partially, I would say, but being a debatable topic, we will not start a debate over here. But MHT is here to stay. In certain cases where there is a first line therapy, we give it for a short term course. Once the thing is improved, as sir has already said, the holistic approach from head to toe, you have to understand that a holistic approach is something which we need to aim and set our goals towards. Like in our Sanskriti, there is yoga, there is Surya Namaskar, there is Chandra Namaskar for the night time, inhaling, exhaling the breath, eating a proper diet. The seasons, I think Gujarat, sir, you are in Gujarat only. So we have got diet for different seasons, different time, everything is affecting. There are different festivals which we enjoy at different time. So I think in accordance with the nature season, if you have a proper diet, proper mental health, proper sleep. So I think that is what you meant for with the holistic approach of
Yeah, so
treatment.
I have only one thing to say. Human history is about 10 million years, and women are here on this planet for 10 million years. Before 200 years, there was no HRT. So 10 million years minus 200 years. How did women survive without HRT for these million of years?
Maybe the lifestyle, maybe the other things would have caused them less problem.
Yeah.
Or so when I was very small, I remember in the fields we used to go. Our grannies used to pick up the fresh vegetables, cook it, and many natural things. As you said, sleep-inducing nuts and seeds are available. Similarly, there are things which are converted into your GIT into the natural hormones. So
Yeah.
now we don't receive that in plenty. So probably that era has gone with them. We are surviving into the era where we have to compete with so many things around, inside out both. So thank you for the valuable discussion today. I really had very much insight to it. Any take home message for our audience gynecologists today?
Take home message, as I firstly said, many women will have you as the first point of contact for insomnia. So in our culture, women will come to you for any kind of problems. They may come to you for insomnia. So so please be aware about this big problem. And um, another thing to remember is pharmacotherapy is not the first line of action for insomnia. CBTI should be developed. We need more and more CBTI programs and other techniques to get rid of insomnia rather than just keep on prescribing some medications for many years. So insomnia is a significant problem, um, and there is a message from the from a patient perspective as well. Women are at a greater risk for insomnia. I would request their family members to take care of the women who have greater responsibilities in this modernized time. So don't ignore the early symptoms of insomnia. It is treatable, it is preventable, and it is curable. So take care of insomnia.
Perfectly said, sir. And I would like to highlight over here that when a lady is disturbed, insomniac, she's running around the house, throwing the things, throwing out the tantrums, irritability. So here's the time where Dr. Nimit and I request you that do jot it down, make a pointers, 10 things list. Sit with your family like you're sitting in the parliament, discuss it out rather than showing tantrums so that they understand that you're really suffering rather than blowing here and there. So probably talking it out, telling your problems to your family members, immediate members, they will understand. Maybe few sessions would be required. And I think as a family, everybody should understand the lady who is into a transition phase has a adolescent daughter, has a geriatric mother-in-law, father-in-law, or parents to take care of. So, and herself, she is into a transition phase where she's fighting with her own problems. So, as a family, probably we, and as a care providers also, we need to have a more ears to those problems to give her a healthy lifestyle ahead, and especially with Dr. Nimit over here, a proper sleeping practices. So important thing is that even the partner, sometimes somebody is snoring or having a different type of habits. I think that is also can be resolved by talking it out and having a proper consent to certain things. I have not touched the topic of sleep apnea syndrome. Probably the next time, only a one word from you, then we can end that. So, or how is it different? And
Sleep apnea is also quite prevalent. And if I was to say only one line, I would say there is a significant overlap between sleep apnea and insomnia. And there is a new term which is COMISA, comorbid insomnia and sleep apnea. So about 30 to 40% of sleep apnea patients have insomnia symptoms, and about 40 to 50% of insomnia patients who are apparently having insomnia, they have some underlying sleep disorder, breathing or sleep apnea. So we just published an article about COMISA in the Indian Journal of Sleep Medicine a few months ago.
that's very right, sir. So I think we have to be understanding that the fact that we have got sleep physicians and menopause or midlife is nobody's own space. So we have to practice multi-speciality so that each and every problems can be dealt up in a proper way. As such, sir rightly said that you would be the first point of contact because of the confidence, the familiarity being a doctor. So I think listen to that. Maybe in the subsequent visits, we need to bifurcate what problem needs what care. Thank you, Dr. Nimit. It was really very nice to talk to you. Many insights and inputs of yours will go with us in a long way and probably will be more sleep savvy in the near future. So when we end this meeting, this gadget has to stop and you have to prepare for a good night's sleep. Thank you, sir. Thank you, support team. Thank you, Dr. Sunita ma'am, for giving us this opportunity to discuss this important issue today. And I think we had been a very fruitful discussion. At least I learned a lot. And thank you for benefiting us, Dr. Nimit. And thank you, support team. Good night. Have a nice day ahead.
Good night. Thank you for having me. Thank you. Take care. Bye.
Bye.